Hi, I'm Dr. Lisa Larkin, and this is HERmeducation video number 2. Today I'm talking about estrogens and the impact on breast cancer risk. So let me start by saying this is an area that I'm passionate about, both as a menopause clinician and as a breast cancer survivor myself. And as you know from my previous videos, I'm also really concerned about accurate messaging. And what I hear on social media and see is that they're screaming from the rooftops that estrogens are not associated with increased breast cancer risk. And I'm going to explain why I personally, as a clinician who sees patients and who had a few weeks ago 3 patients within 2 weeks with a new diagnosis of breast cancer, and I prescribe a lot of hormone therapy, I want to explain how I, as a clinician, talk to my patients about the sum total of the data and why I believe that saying and screaming from the rooftops estrogens are not associated with increased breast cancer risk is not 100% accurate. And I think we need to have more nuance in the messaging. Now, I know that many of you are going to disagree with me. And again, I welcome professional comments on this post. And again, if you can provide me references, I'm happy to have that. And again, I welcome anyone to message me about having a Monday night discussion group specifically on this topic to dispel some of the things I'm about to say. So where does a lot of our data come from, and where does that messaging come from? It comes largely from the data that we got from the Women's Health Initiative. And although that data has been thrown under the bus in a lot of ways, and certainly I agree that the way that the data was presented in the media in 2002 about the association with increased breast cancer risk in the Premarin plus MPA arm was blown way out of proportion and has largely caused harm because of fear of menopausal hormone therapy. But let's look at the data. The WHI estrogen alone arm, which was Premarin specifically, showed a 22% reduction in breast cancer. The Premarin plus MPA showed a 24% increased risk of breast cancer. So if we think that the synthetic progestin is the problem, then we are saying that synthetic progestin alone, which of course we don't use for menopausal hormone therapy, would be associated with a 46% increased risk of breast cancer. We don't have that data to say that. We think that there's an increased risk with MPA. We don't know the magnitude of risk because that has not been studied. The other gap in data is that we don't have a comparator arm with estradiol plus MPA in any kind of randomized trial, and we're not likely to have that. But again, I think we must all be careful about thinking about Premarin compared to estradiol as it influences risk. When we talk about the impact of menopausal hormone therapy on breast cancer risk, we do a lot of discussion about the progestin influencing the risk and being really the problem. So we know that there's a difference between MPA, medroxyprogesterone acetate, norethindrone acetate, and progesterone in terms of risk. But when we're talking about estrogen and how it influences risk, we conflate estradiol with Premarin, and we, even in the meta-analyses, we're lumping all of that data together, and largely the most data we have comes from Premarin. And so we aren't doing enough, in my opinion, about distilling the data between estradiol and the impact on risk and Premarin and the impact on risk. And I think many of us believe that Premarin, acting alone in the WHI, may have SERM-like properties, and that's why the risk is reduced. We don't have the same RCT data on estradiol alone. We have some limited data, we have some estimates and meta-analyses, but again, it's very muddy data because we don't have the same RCT of estradiol alone compared to estradiol plus MPA and comparing that to the data that we got in the WHI. And I think language matters because when we're thinking, as we move forward with some newer hormonal developments that's happening in the menopause space, that there may be very differing impacts on breast between estradiol, Premarin, ethinyl estradiol that we use in oral contraceptives, and now E4 or S-tetrol, which is working its way up the pipeline. So what do I believe the data supports in terms of messaging? Well, certainly I think that we can clearly say that in the WHI, Premarin alone reduces breast cancer risk. And we can say from the WHI that Premarin plus MPA has a slight 24% increased risk of developing breast cancer, but no increased breast cancer mortality. What I don't think we can say is that exact same thing when it comes to estradiol. And although I believe that the data suggests a small risk, and again, less than we see with obesity or daily alcohol consumption, so I don't want to overblow the risk, and I think it's small, but I don't think we have data to say in the same way that estradiol by itself has the same reduction in breast cancer that Premarin does. So when I look at the data, and the way I think about this is I believe that Premarin is likely positive when it comes to the breast. And why do I say that? Not just from WHI data, but we know that there's recent data out about Duavi, which is Premarin, conjugated equine estrogen, and basodoxifene. And there's both animal and preclinical data and now some biomarker data in women showing reduction or factors that look like it reduces breast cancer risk. And I believe this is likely related to the Premarin. So I go back to what about estradiol? And although we don't have RCTs, again, looking at estradiol alone, just estradiol and its impact on breast cancer risk, we do have preclinical trials comparing estradiol to Premarin. And it looks like, in fact, estradiol does not have the same reduction in animal models and preclinical trials that Premarin does. The other caution that I have is about the data when it comes to understanding what a woman's individual baseline breast cancer risk is before she starts taking menopausal hormone therapy. And I personally believe that this is incredibly important. There's a suggestion out there that baseline risk does influence response to menopausal hormone therapy. And I believe that the future really is pharmacogenomics, genetics, helping us understand individual variations in women. And some women, I believe, we're going to see have significant increased risk when taking hormone therapy when it comes to breast cancer, and others may have reduced risk or no risk. But I think we don't have data. None of the trials, especially the WHI, teased it out. We weren't doing breast density then. We weren't really using validated risk models in any kind of way like Tyrer-Cuzick. And so we don't have robust data to look at the women in the WHI who developed the breast cancer and those who didn't, and see if their baseline risk and their baseline breast density was different between those two arms. And I predict it was. So what do I believe? What's my take home? I believe that stating that estrogens do not have any breast cancer risk is misleading and not based in the data, because we're conflating Premarin with estradiol, which is what most of us use in most circumstances now. And so what I believe is much more accurate messaging is that we should be saying to women, yes, if you take Premarin alone, you likely have a reduction in breast cancer risk. And that's probably true with Duavi as well. But when we're prescribing estradiol, what do I say to patients? Which is that the risk of estradiol is probably quite small, but I'm not sure that it's zero. I take into consideration their baseline breast cancer risk, and I counsel them that potentially if they're very high risk, say 30% lifetime risk, that the impact of menopausal hormone therapy, estradiol, on them is likely higher than it is on someone who has a baseline breast cancer risk of 12%, or fatty breasts, or low density. And so again, I think what we have to say to women, in my opinion, is that the data when it comes to estradiol and progesterone is not as clear as it is with Premarin alone in terms of showing a reduction in risk and safety. And that when I am prescribing hormone therapy, that I say that formulation matters, dose matters, duration matters, baseline breast cancer risk matters, and this is why individual menopause consultations are time-consuming and complex and need to be very individualized. But I think there's a big difference between saying that and saying that menopausal hormone therapy or estrogens and lumping all estrogens together carries no risk is not the sum total of the data and is not accurate messaging. Again, I know many of you out there may disagree with me, and I have read Dr. Blooming's book, Estrogen Matters. I welcome Dr. Blooming to come on a Monday night discussion group and again, explain to me why he disagrees with my statements on this. If any of you can find, because I haven't, RCT data of estradiol alone looking at breast cancer risk, I welcome being educated and I want to have continued conversation about this. Again, I'm not out there trying to slam anyone and make enemies. I want to have accurate messaging for women because I believe they deserve that. And again, if you think I'm wrong, please leave comments, please leave references, and just do it in a professional way because again, we're all on the same team and we want the same thing.